I graduated from my first nursing degree at Tompkins Cortland Community College in 2007. Graduated in 2013 from Keuka College, and now my master's. So I currently work at CPEP, which stands for Comprehensive Psychiatric Emergency Program, and that is at UHS, Binghamton General. UHS has 3-4 hospitals that is under the healthcare organization, as well as many clinics. The reason why I chose telepsychiatry as part of my capstone is that, like Roseanne said, there are numerous visits to the emergency room. A lot of those visits are psychiatric and behavioral health, mental health issues. Unfortunately for nurses like Roseanne, they don't do psychiatric emergency evaluations. The only emergency room in our catchment area that does it is CPEP at Binghamton General. And so, because we're bogged down by psychiatric emergencies, it bogs down the emergency room. And the problem with rural hospitals is that they're saddled, unfortunately, I'm going to use the word saddled, they're saddled with a patient who has a psychiatric problem. They don't have a way to assess, because they don't have nurses or doctors or psychiatrists that will assess them. And what happens is they have to wait for another hospital or a psychiatrist to go to them, or they transport to us. So we're going to talk about my objectives here. First, to understand the current mental health problems of New York State. We're going to review services for the rural mental health patients. I'm going to describe the current services to improve mental health outcomes. And I'm going to talk about the psychiatric nurse practitioner in the ED and describe a proposed qualitative study. This shows effectiveness and hopefully satisfaction. Background. Currently, according to one research study, a quarter of Americans have a mental illness within their lifetime. That's greater than 60 million Americans. New York State, New York State has decided to reduce services at the state level and county level, which means that state hospitals have reduced beds, they have reduced services, county levels, and our county, Broome County Mental Health Clinic, is closed. So less than 2,000 people that utilize the Broome County Mental Health Clinic now have either no services or are trying to find services, or they're going to those outpatient clinics that have had to kind of pick up those patients. A lot of the patients in our catchment area, which is 9 to 10 counties between New York State and Pennsylvania, live in rural and remote areas. And Roseanne and I, Roseanne's still an EMT, I was an EMT. A lot of that area is very remote. Dirt roads, places that take 20 to 30 minutes to get to our hospital. Because mental health patients aren't getting their services, they get misdiagnosed. Their actions put them in jail. That increases the jail population. And most of those people don't want to be under mental health services. There's a stigma. They don't want to be labeled crazy. And that puts a burden on primary care physicians who don't really understand psychiatric psychopharm medications. Problem again, we've reduced mental health services. They really don't exist for Broome County Mental Health Clinic. And Broome County Mental Health Clinic used to do what's called the involuntary transports. So now all of these other clinics have to pick up that responsibility of issuing an involuntary transport, which is called the 945. Or police departments have to decide whether the issue is a psychiatric issue or a criminal issue. The rural hospitals then have these patients that are sitting in their emergency rooms. They call us or they don't call us and transport patients to us when they could have just sat in their emergency room, waited for a proper evaluation. So there's the time invested that we no longer have for mental health patients. Those outpatient services that are picking up Broome County mental health's many patients, now the appointments are 2 to 6 weeks out. Imagine having an emergency. And those clinics didn't then hire more people. They're picking up the slack as well as they can. And primary care physicians can't meet the demand. Mostly because the problem with the primary care physicians is they didn't really know psychopharm. The psychiatrists that we have now have aged. There's a lot of nursing students that want nothing to do with mental health, as well as medical students who do not want to go into psychiatry. They're wanting to go into vascular medicine, surgery, orthopedics, so we can't even attract them to psychiatry. Is there a solution? Again, let's review. There's the geographical, rural, remote patients that we can't even reach. There's the stigma behind that. Most of those people in the rural, remote areas don't have insurance. And even if they got to a more urban area, there might not be any services for them. Those patients, whether they're suburban, urban, or rural, still don't want to use mental health services. They don't want to be on medications. They don't want to be labeled as somebody who needs that kind of help. Their families don't understand. Heck, a lot of people in the health industry don't understand mental health issues. And people who have a significant problem, maybe they haven't been diagnosed. They don't understand these predictive behaviors. They're not measuring that they're getting worse or they're at their most urgent need to get help. Is there a solution? I think that introducing video conferencing or telepsychiatry. Telepsychiatry is the use of the internet with a camera, such as the computer, and just talking to the patient. You know, we have real-time counseling with that. I've said, even this week, we had a situation where a hospital was calling me and saying, we have a patient whose blood alcohol is 2.3. We're going to wait until their blood alcohol is less than 0.08. We're going to send them to you. Well, what's the problem, doctor? Well, they made some suicidal statements. Okay, you're going to send them to us. In all likelihood, they were drunkicidal. They are not going to remember they made a statement. And that happens probably greater than 75%. They don't even remember they said anything. So they've been transported to us from Delaware County, which is a little more than an hour. We assessed him. He was no longer suicidal. Then it was our responsibility to get him back to his home. I really believe that telepsychiatry is a delivery of method that we can use. It's so inappropriate to utilize the kind of money that we waste in hospital systems. And we can accurately diagnose people even with telepsychiatry. So here's an example. Patients in the emergency room. It looks like Lourdes because Binghamton General doesn't look that nice.
It looks like one of our ER physicians too.
So, you know, it's something that we would just kind of introduce. It's not something unheard of. We're already using electric medication. We're using e-medicine to kind of calibrate people's pacemakers. We're using it for wound care. It's not unheard of. And we actually are behind the times. All of South Carolina is using telepsychiatry in this fashion. Again, it's the means of using audio and visual signals, using cameras and microphones to diagnose, manage, treat, provide therapy. In psychiatry, you don't really need to use many of your other senses. You really need to just be cognitively talking. So this is a really good idea for our area. Opposition, there's a lot of opposition. Psychiatrists want to do the face-to-face interaction because they believe that the rapport isn't there. It's not humanistic enough. There's a lot of situations where if you were to evaluate somebody, you can't smell that they're having issues. They might, for some of our patients, they haven't been taking baths, but they look all right. If they were on the screen, they might look okay, but you don't smell that, you know, they have been sitting in their urine forever. You miss nonverbal cues. You might miss those cues with the people who are alcohol abuse or going through opiate withdrawals. You don't see the tremors, the nervous behaviors, the tics, some of the side effects of psychopharm medications. The problem with doing telepsychiatry is the expense of the equipment. There aren't hospitals that, especially on the rural end, there aren't hospitals willing to spend the money on this. And we know that there are spotty internet issues. We have them, and we live more urban than those rural people. The rural patients may not be willing to use technology in that fashion, as well as they have to learn how to use it. On our end, we have to educate staff to use it. And there's the privacy issue, the confidentiality issues. Is it HIPAA compliant to use telepsychiatry? So I proposed that, as I was doing this paper, I proposed that, yeah, there's a way for advanced nurse practitioners to really be in the emergency room, to kind of triage emergency care. And the issue is that I think psychiatrists in the hospital do not want to let go of that idea of we're making the decisions. Nurses really need to just do what we're telling them to do. But as I did this paper, I realized psychiatric nurse practitioners do have a stance in how we're going to kind of mitigate some of the traffic flow. And in all honesty, we already do it anyways, because the ER is run by nurses. We're the charge. We have to make things happen, and we direct the traffic. So why not have a nurse practitioner to mitigate interventions and make recommendations alongside the emergency room physician? So the theorist that I worked with was Katie Erickson. She was a Norwegian nurse, and she theorized that her biggest theory of nursing was the relationship between patient and nursing. It was based on respect, dignity, caring. And she also said that suffering was part of the patient's event. And our relationship with that is to kind of minimize the suffering. I also talked about Everett Rogers' theory of change. I really like Everett Rogers' change theory because it parallels the nursing process. He talked about nursing processes, assessment, diagnosis, planning, intervention, evaluation. Everett Rogers talked about knowledge. So if we were to apply this telepsychiatry, it would be the nurses that would be the change agent in getting this on board. We're going to make this happen. So we'd have to persuade people, and we'd have to get the knowledge, understand what it's going to take to do this. So knowledge, persuasion, deciding how we're going to do it, when it's going to happen, implementation, and confirmation. So similar to the nursing process that it just flowed very nicely in my paper. My literature research, I narrowed it down to 6 papers in my paper, as well as then narrowed it down to 3 papers within this PowerPoint. This research was in Australia, and as you can well imagine, there is just vast geographical areas in Australia. And what they did in this research study is they studied over 1,900 patients who were in outlying areas and decided after this research how they could reduce the transfers to the main psychiatric hospital. And what they found is after utilizing video conferencing, they actually reduced the transfers by half. But what they did find out was the patients' age were more males, and there was an increase in the age of those patients that were coming in. So, but they did show that the patients were happier doing it that way because they didn't want to go from their home hospital to this main hospital for care. Another research study, and this was a research study of women who were reporting depression. They put an ad in the paper, asked for people who were willing to do telepsychiatry. 17 women decided to do it. 16 people actually did the survey, and they did the telepsychiatry for 10 one-hour sessions. They asked them to fill out the survey after the 10 sessions, 3 months after and 6 months after. And what they did realize was that these ladies were very happy. 2 of them weren't too happy with it, but those 2 people didn't find any rapport and empathy from their therapist. And I think that's what we're going to find with telepsychiatry, is that people aren't going to feel like they've got some kind of rapport, or they're not getting. And with mental health patients, if you're not telling them what they want to hear, obviously they're not going to be satisfied. So it's a fine line with a lot of patients. And the last research was the benefits of telepsychiatry for rural nursing home patients. And what they did was they evaluated the travel time, the expense of the patients going to the doctors versus the doctor going to the nursing home, and personnel costs. What they had decided was that they saved a greater than 840 hours of travel time and saved 43,000 miles in travel time. And when they asked the patients, the family, and the personnel of the nursing home, they were very, very happy with this. I think the problem with this study was only one nursing home, and what could have been a little bit better is multiple nursing homes. So my proposed study was using a survey after utilizing telepsychiatry. When I started this nursing degree, there was actually a proposal that never came to fruition to use telepsychiatry between Binghamton General Hospital and Delaware Valley. It never came to fruition. I don't know if it was because Delaware Valley didn't want to do it, but we were on board. We were all set to do it. It's never happened. So my thought process is, how do I measure effectiveness? I think my measurement of effectiveness is whether or not the patient felt satisfied in the assessment. So this is part of my Likert scale. I would ask, did you have privacy in your work session? Did the mental health nurse display competency when she was talking to you or he was talking to you? Did they show concern? Because if you're measuring mental health satisfaction, you're going to want to measure empathy. Does the patient feel empathy and sympathy from their provider? So the outcomes, hopefully, we would improve the access, because really, in all honesty, the only two ways you would get psychiatric care is a face-to-face session, or you're admitted to the hospital. I think this is a nice in-between. Who wants to be in the hospital? But if you can't get a face-to-face session because the appointment's 2 to 6 weeks out, and sometimes 3 months, this might be a nice way to do it. It excludes transportation from the patient coming to us or us going to them. We do mobile evaluations to Ward's Hospital, as well as Wilson Hospital, as well as school evaluations. We've done home evaluations. The problem with home evaluations is we have to take 2 people out of CPUP because that's not appropriate. We need to have a second person. The real-time assessments, it can be done right then and there. We've known that telepsychiatry is already used in EDs, in jails, educational facilities. We're just not using them. In the jails, they've been using them. Broome County Jail uses it now. In educational facilities, the problem is we see probably 2,000 children a year. A lot of that is just a behavioral problem. They didn't need to come through this ER. The ER visit is 4 to 5 hours. They have to go through the ER. They have to be medically cleared, and then they come and see us. We need to kind of move this process along. We can use it in nursing homes. It reduces ER time. This is when Roseanne is going to get silly and start using those jokes because she's got psych patients in her ED.
Oh, God, sure do.
It decreases the cost and time for providers going to that patient, whether it's in a clinic to their more rural area, because they can see more patients sitting in their own office. It does allow for privacy. It is shown that there are programs that have already been introduced that doesn't have a confidentiality problem. The hospital just needs to find that one that they want to use. I think as telemedicine becomes more mainstream, you're seeing video conferencing in schools with with even children who aren't able to go to school, and they have a robot with a monitor, and they're going to school, they're going to classes. I think as they become more mainstream, patients are going to want this as a secondary or tertiary means of getting services. So the outcomes for nursing, I think that this is really an avenue to nurses being in the emergency department, being a provider, not as emergency room nurses, being advanced practice nurses. It's immediate care for them, it manages the ED, it integrates the specialized care in the ED. I think it utilizes greater communication between all the charge nurses in our 3 hospitals in our city. We can be talking to each other, utilizing this system to kind of communicate what the needs are. I think just yesterday, Lord's had a patient who was sitting in the ER the night before I came in on day shift, and I had to send an evaluator to them, but they've been sitting in the ER for 12 hours at Lord's. So I really believe that this is a way for all of us charge nurses on our shifts can be talking to each other and kind of driving the traffic and mitigating some stalls in our times of getting people seen and then discharged. It's positions nurses for education, management, training, interventions, and further research. I think that we're in a position, and I go back to the first essay that we had to do before before we came into Keuka, that the Institute of Medicine said that nurses need to practice at their highest level of care. We have psychiatric nurses who are prepared to kind of help emergency rooms. And I think emergency rooms need to be okay with this, facilitate this. So I have a little video. I'm not advertising anything. It's a video. I think that once you see it, you'll get an understanding of telepsychiatry.
Mr. Green? Mr. Green, I'm over here on the screen. I'm Dr. Black, and I'm here to do a psychiatric evaluation. I know it's a little bit unusual, but I want you to feel as comfortable with me here on the screen as you do with Nurse Jackie there, okay? Can you tell me what's been going on in your life?
I don't know.
And how long have you felt this way? When did this start?
Just sort of all happened one day. Came out of nowhere.
Have you been taking any kind of medication for this?
Yeah, I was on some antidepressants, but that didn't help.
And are you still taking the medication?
It didn't really seem to be much use, and
Well, we're going to work together on this. And I know that in time we'll be able to get you back to the way you were before. Okay? So let's get started, shall we?
Well, I really think there's an avenue for us to utilize telepsychiatry in our emergency rooms. Even if we don't have it at Lord's or Wilson, or have advanced practice nurses in those emergency departments, I really think that we can at least kind of review or investigate this as a means to deliver services to patients who don't have it, haven't had it, need it. Any questions?
Just comment just to collaborate with you regarding the wait times. You know, coupled with the intense utilization of all the EVs, lately the people waiting to do psych evals, it's been at minimum 12 hours or more at Lord's, because you guys are so busy at your ED that we have to wait till one of your evaluators is available to come over. I can see this as, boy, this would be so advantageous to cut down on those length of stays. I had that patient that you had the 12-hour one. I had her. So
I failed to mention that when I was writing this, and I told Deb, when I was writing this paper, I realized I'm in that position. I'm in that position to be the advanced practice nurse. So after I wrote this paper, I talked to the director of psychiatry. After I heard that I was accepted at BU, I asked him for 5 minutes of his time. He's very busy. And I sat down with him and I said, I am not leaving the emergency room when I become this nurse practitioner. I want you to make a job for me in the emergency room. And he said to me, that would really help me out. So I'm hoping this actually comes to fruition for me. Thank you.